Hi, my name is Arjumand Siddiqui. This is Module 1, Section 1, Conceptual Introduction to Social Epidemiology. What we see around us in medicine and in public health is a great amount of attention to social determinants of health and health equity. This is a sample taken from websites and reports of some fairly prominent institutions in our society, everything from Public Health Ontario to World Health Organization, Canadian Institute for Health Information, CIHI, just to show that these are all organizations that are putting a fair amount of effort and energy and attention into matters of health equity. And this course is really designed to talk about the science behind health equity and to enable people to do the science on this work and to participate in growing our knowledge base around this work. And so this course is really intended to give you the conceptual and methodological foundations to do this work. The work actually has a very long history. So in this slide, you see two examples of work that was conducted in the 1800s. On the left is a study that was conducted by Villermé, and that study involved looking at mortality rates and their differences by neighborhoods. And what you see is an attempt to show that your neighborhood conditions were associated with your risk of mortality, here measured by proportions and rates of mortality. On the right-hand side is a study that was conducted by Engels, and similarly, the objective was to figure out if mortality differed by your social conditions. And in that case, Engels looked both at your social condition, the social conditions of the street on which you lived, and the house quality on that street. And so it was sort of a mix of sort of a more contextual measure through street and a more sort of individualized contextual measure or socioeconomic measure through the class of your house. And again, finding differences and sort of gradients in mortality across both streets and within streets across classes of houses. This work trudged on, and it was about the mid 1990s when we started to see an assertion that we can actually make some broad conclusions from the literature that has developed in this field. And in 1994, Nancy Adler and her colleagues penned a rather sort of important commentary, which they called The Challenge of the Gradient. And it was about what we know about the relationship between socioeconomic status and health. And what her colleagues and her pointed out was that if you look at the swath of studies on this topic, what you generally see is a stepwise association between socioeconomic indicators like education and income and health outcomes. And in saying that, what she was saying is that the stepwise association is in contrast to, say, a binary association. So it's not just if you're in very poor circumstances that your health differs from others. It's a stepwise association between how sort of resourced you are socioeconomically and what your health status is likely to be. And and Professor Adler and her colleagues sort of pointed out that we see this relationship across every health outcome that we've studied, across various socioeconomic indicators, and across all societies in which we've been studying this relationship. So, one question that emerged is whether that relationship between socioeconomic status and health suggests, as Professor Adler and her colleagues were suggesting that socioeconomic conditions cause poor health versus the idea that poor health leads to a decline in your socioeconomic resources. And you can imagine that either could be the case if you have a health condition emerge that prevents you from, say, working or working to the extent that you were working before. That can lead to declining income and so on and so forth. And part of the problem was that a lot of the research that had been done used cross-sectional designs, meaning socioeconomic status and health outcomes had been measured at the same time or analyzed as if they had been measured at the same time. And so here's an example of a study in which the authors have looked at the relationship in men and women between your employment grade and how high functioning you are according to a measure called the SF short form 36 physical functioning score. And the authors find indeed a gradient, a sharper gradient, a more clear gradient among men, but nonetheless a gradient by employment grade in your physical functioning score, so that the higher your employment grade, the better your physical functioning score. But the question really is whether or not it's actually that your decline in physical functioning score might be what leads to a decline in your employment grade. And so if you use a cross-sectional study, it's difficult to disentangle which element is causing which. Well, in order to resolve that problem, scientists started to do prospective studies, meaning that they would study your socioeconomic conditions at baseline and how your health changed after that. And so this is another study that did just that. It looked at cumulative socioeconomic conditions over the life course and sort of the trajectory of socioeconomic conditions over the life course, and looked at the relationship between that and your incidence of the population incidence of type 2 diabetes, meaning the risk of developing type 2 diabetes. And it found indeed that the lower your SCS, the lower your socioeconomic conditions on both measures of socioeconomics, the higher the risk of developing type 2 diabetes. And over a course of a literature, I think what has been established is that the majority of the relationship between socioeconomic status and health is socioeconomic conditions leading to poor health outcomes, even though both are possible. So now that we've established that socioeconomic conditions are a sort of cause of poor health, how do we explain that? And I would contend that the majority of the explanation that we have come up with in public health has been focused on behavioral risk factors. And so the idea is that people with fewer socioeconomic resources and in living in lower socioeconomic conditions are prone to have worse health behaviors, more risky health behaviors than people with high socioeconomic conditions, high socioeconomic status. And this is just a sort of on the left conceptual framework that kind of highlights that. And the gist of it is that it suggests that there are a variety of social conditions that then influence one's ability to eat right, to exercise, and so on. And on the right are some sort of local Canadian programs that have been tailored to examine how to improve health behaviors amongst more socioeconomically compromised groups. And this is a very common strategy in public health to sort of figure out whether there's a program or an intervention we can offer that helps improve health behaviors in socioeconomically disadvantaged populations. So if you look at the data, it's actually quite variable in terms of the extent to which behaviors actually account for the relationship between socioeconomic status and health. This is an oldie but a goodie study that looked in the blue bars at the gradient in the risk for mortality across income groups. And this is a US study. And so they used people who earn over 30,000 as a referent group. And they examined what the risk of mortality was in comparison to the earners of more than 30,000 in two groups. One group that earned 10 to 29,000 and another group that earned less than 10,000. So both earning less than the referent group. And if you earned between 10 and 29,000, your risk of mortality was over twice that of people earning over 30,000. And if you earned less than 10,000, your risk was more than three times that of people earning more than 30,000. And so again, you can see this gradient effect in mortality across income groups. And then they asked the question, what accounts for that relationship? And they did that by saying, what happens to the crude association between income and mortality if we adjust out the effect of several health behaviors? They also adjusted out age, race, and sex. And those are all sort of demographic characteristics, and we can sort of have a conversation about whether it's appropriate to adjust for them or not. But if we just put that aside for a moment and focus on the fact that they also adjusted for smoking, alcohol index, and alcohol intake and body mass as a sort of proxy for diet. What they found is that adjusting for those variables resulted in what you see in the gray bars. And so if you look at the gray bars, what you will find is that indeed some of the relationship between income and mortality goes away, but not a heck of a lot of it, not very much of it. So, in other words, smoking differences, alcohol intake differences, and body mass differences across income groups did not account for very much of the socioeconomic gradient. This was not primarily a gradient that is driven by health behaviors. In another study by one of our course's co-instructors, Dr. Sylvia Stringini, we find a similar thing, which is that if you look at predicting premature mortality and you ask yourself whether the risk factors of smoking, diabetes, physical inactivity, alcohol intake, hypertension, and obesity would reduce or account for premature mortality, what you find is that indeed they have an effect, but that in that top line there, socioeconomic status is a risk factor even after you account for such major risk factors for mortality. It has its own weight even after adjusting for many of these factors. So we actually have some theoretical and conceptual underpinnings to explain what's going on, to explain why behaviors don't in and of themselves account for socioeconomic differences in health, and to explain why you might control or account for hypertension and diabetes and so on, and still find that socioeconomic status has an effect on mortality. And there are sort of insights like this one from a neuroendocrinologist, Bruce McEwen, who tell us what the underlying biology is and how that might be related to social conditions in a way that might explain and reconcile all of this. So if you look at the top level, top line, if you will, of this framework, you see environmental stressors, major life events, trauma, and abuse. Those are effectively what he looked at as sources of external stress or strain. These are, if you will, the social conditions and how they manifest. And what the point of this sort of conceptual diagram is to say those social conditions, those circumstances, life circumstances, then are perceived by the brain, and the brain then begins to think about a response and to activate a response, to perceive a threat, to perceive that the person might feel helpless, to kick in a sense of vigilance against the threat. And that takes the form of many things. One, if you look to the right, is that it does result in changes in behaviors. So one effect of experiencing this kind of stress is that you may change your health behaviors, your diet, smoking, exercise, drinking, etc., may be influenced by the level of stress you perceive. But that's not the only manifestation of this kind of stress. If you look straight below the diagram of the brain, what you see is a physiological response. And the idea is that the human body has physiological responses to stress that kick in irrespective of responses that operate through health behaviors. And these physiological responses to stress are called allostasis or adaptation. And the idea that your body has a physiological toll that comes with experiences of stress is called allostatic load. And on the left-hand side, you'll see that all of this may be moderated, changed, different across individuals with different experiences, across individuals that have different sources of resilience to cope with stress, and so on. And it behooves me to say there's one other really important thing about this model, which is that a lot of it is predicated on the idea that the stress we experience from our social conditions is chronic stress. This is not about occasional major stresses that happen. This is about everyday, all day sort of insults, moments of difficulty, sort of lack of resources to make decisions that you want to make, and the stress that comes with that. It's the low grade chronic stress that's really important for health in terms of social conditions. And we can see from studies of this that socioeconomic conditions really do predict how much physiological toll of stress people experience. So this is a study that looked at income-based differences in allostatic load over the life course. And the top line is the allostatic load of people who have less income, in this case, a poverty to income ratio less than 1.85. And the lower line is people who have a poverty to income ratio of 1.85. And what you see is two things. One, that people who are poorer have higher levels of allostatic load. Again, that higher level of accumulated physiological toll of stress. And the bottom line, again, suggests that people with lower income have lower levels of physiological stress, of allostatic load. And you also see that the level and the difference of allostatic load changes over time. And so you see larger differences toward the end of the life course. And that could be both because there are things that are more stressful that you're dealing with, but also because of this cumulative chronic nature of allostatic load kind of building up over the life course and affecting health because of that. And allostatic load is effectively a combination of physiological indicators that include things like blood pressure, but also the functioning and release of stress hormones, and so on. So let's put all of that together. The idea that we have socioeconomic differences in health and that these differences are sort of mediated, explained mechanistically by a range of things from health behaviors to allostatic load and beyond. And this is the World Health Organization's conceptual framework on social determinants of health. It is sort of fairly ubiquitous. It's, I think, a very clear framework, but there are others that you might see that are similar as well. And what you see on the left-hand side is an explication of social conditions that might affect health. So we've focused so far on socioeconomic status, but there are many other indicators of your social conditions, including your gender, your race, ethnicity, immigrant status, and so on. In fact, many argue, and many of us, including a couple of the co-instructors on this course, have done work to say that social conditions are actually also our societal conditions. People have worked on neighborhood conditions. The idea is that there is a range of social conditions, and that range of social conditions affects a range of mechanisms that lead to a range of health outcomes. So social conditions affect health behaviors. They affect our physiological stress mechanisms. We have studies that show they affect epigenetic processes and telomere length. There are a range of mechanisms that they affect healthcare access and so on, environmental toxins, exposure to viruses and bacteria. And all of that affects health in one way or another. And in fact, in 1995, a really important paper came out that effectively tried to underscore the theory and explain a theory in systematic terms of how this all works. And that paper essentially said social conditions are fundamental causes of disease or of health. And what they mean is that social conditions, again, those factors that are sort of more upstream on the left, provide flexible material resources that affect health and trigger mechanisms for health. So they provide income, they provide housing, they provide food, they provide all sorts of things that you can decide what you need and what you want to do with and at any particular time. So it's a store of sort of resources that enable you to kind of live a healthy life, or if you don't have them, make you vulnerable to not having the conditions for health. So, as a fundamental cause, that they are root causes, and that's what makes them so important. So social conditions are important. Social determinants of health, as they are often called, are important because they are at the root end of almost every mechanism leading to almost every health outcome. So they aren't just another determinant. They actually activate the other determinants of health. And what the theoretical paper suggested is important about them, in addition to the fact that they affect almost every mechanism and every health outcome. The consequence of that, they suggest, is that if you block one downstream mechanism, let's say through a behavioral intervention, the problem is without fixing the root causes, the socioeconomic disadvantage that people experience in some groups, the power of that socioeconomic resource or lack thereof will operate through a different mechanism. So if you create a very effective behavioral intervention to improve diet and reduce type 2 diabetes, socioeconomic conditions will find other ways to affect type 2 diabetes and other health outcomes through stress, through epigenetic processes, and so on and so forth. So the idea is downstream interventions are fine, but they don't take into account what we know about how health works, which is that it is fundamentally driven by social conditions. And if we don't address those conditions, somehow, some way, the downstream consequences and the health consequences will keep going. So I wanted to point out an alternative kind of framework, if you will, that you may or may not have seen. This is produced by the Canadian Medical Association, and it's an infographic that essentially says, if you were to think about your health as being determined by a set of factors that add up to 100%. Well, 25% of that is your healthcare, 15% is your biology, 10% is your environment, and a full 50% is what they call your life, or effectively your social conditions. And so the point of this infographic is to tell people that even though things like genetics may matter, that most things are really about your social determinants, which is kind of consonant with what we've been saying. On the other hand, this infographic kind of conveys the idea that your social determinants are sort of separate from your healthcare, your biology, and your environment. And I think what we've learned is that that's actually not the case. They are not separate from these issues. They are bound up in your access to healthcare, your biology, your environment, and so on. I just want to end with a last note on nomenclature and terms that we hear a lot. So, very often we hear the term social determinants of health. Sometimes we hear societal determinants of health. I often use social conditions or social factors. And I think that for me, the issue is that you want to convey that they aren't just singular indicators, but they are indicators of a set of social conditions and processes. So these names and nomenclature aren't terribly important, but it is useful to sort of know that they're used somewhat interchangeably at least, and that they can have deeper meanings if you sort of think about them a little bit more. But I think by and large, the key is that social determinants and social conditions or social factors are sort of the ball of social kind of exposures that we're interested in. And then there's the term health inequities or health inequalities or health disparities. So these are all terms that indicate unequal health status in society across people who are members of different groups and societies. In other words, social groups and societies carry different risk for health status, and the unequal health status across those social groups are considered health inequities, or as I say, health inequalities or health disparities. Very often we hear about the strict definitional way of thinking about this, which is that health inequalities means that you have a difference in health status, and health inequities means that that difference rises to the level of health inequities, which is true for the relationship between social conditions and health. Or put differently, it's true for the fact that social groups have different health status. The problem is that in the literature, it doesn't quite work in those strict terms. People use health inequities, health inequalities, and health disparities as rather interchangeable. Often in the US literature, you will see the term health inequalities. That doesn't mean that they don't believe these are inequities. In fact, one might argue that if you're talking about socioeconomic health inequalities, that's all you need to say, because how could there be anything else but an injustice there? But by and large, I think what I'm saying is there are strict definitional differences, But in operative terms, in terms of the scientific literature, that's actually not how you see the literature kind of unfold. These terms really do get used interchangeably. And finally, I'll just say a word about social epidemiology, which is the umbrella field that studies the relationship between social conditions and health, both trying to understand the social distribution of health and to understand the causes of that distribution. Thanks so much.